Yeah, is that okay?
Yeah, perfect.
Okay, thank you. Okay, it's noon, and I'm sure people will join as they get to the Zoom. Hi, I'm Anita Palapu. I'm the head of the Department of Medicine at Providence Healthcare and at UBC, and it is my pleasure to have our first grand rounds of the season. Usually it's the Arthur Dodick Lectureship on Professionalism and Medical Ethics, but we've decided that our guest speaker wants to come in person next year, so we are being very optimistic we're going to have a vaccine by then, and that's where I have my fingers crossed. However, we are very lucky to have great people within our own organization who can share with us new developments and how we're planning on managing COVID going forward in the ambulatory setting. So presenting today are Doctors Alyson Wong, who's a new recruit to the Division of Respirology, and everyone knows Dr. Adeera Levin, who's the head of the Division of Nephrology at UBC, and also the Executive Director of the Provincial Renal Agency. She has many more roles that I'm not going to go into detail, but we are just delighted to have them speak of people systems and uncertainty, the development of post-COVID recovery clinics for improving care and understanding. So I'll hand it over to our speakers. Thank you so much.
So thanks, Anita, and I'm going to start, and then Alyson will jump in, and then I will continue on. So thank you all for making the time on a first real Thursday, it feels like, now that we're back in real time. And we're really presenting this on behalf of many, many colleagues and importantly, patient partners. I've started to list some of them on that slide, but on the next slide, whoops, Alyson, you're gonna have to help me.
There you go.
Yeah. Okay, on the next slide are all of the people that have been involved on a regular basis. So many people with diverse perspectives and skills that have committed so much time. I've highlighted for you there the names of our patient partners, 2 of whom have had COVID and 2 of whom are at risk for COVID. I want to acknowledge that all of the people listed here from multiple health authorities and disciplines have really contributed to our thoughts, understandings, and the things that we're hoping to present and stimulate discussion around. So what we wanted to do was really to help this group, as a Department of Medicine and others, understand the current state and clinical presentations of COVID, really provoke some thoughts about how we learn about new diseases and what we do and don't know, and some principles around how we manage and care for and with people with COVID-19 who may or may not have other conditions, and how we integrate clinical care and research in a novel way that we're uniquely positioned to do in this province. So I like this slide. It's a Banksy slide, but I really think that we need to acknowledge that, that in this moment, we're all very much affected by COVID-19. And it's not just the communities and families that we serve and people with and without medical conditions, but it's also our patients that are waiting for procedures and diagnoses and just usual care, and all of us as healthcare professionals and staff working, as well as administrators and researchers. And so we've really had this condition, this disease has had a major impact on all of our ways of doing business. And I think it's really important for us to acknowledge that and have a place and space to discuss it, not today, but just for us to see that. When you look at the health impact of a pandemic, it's important that people have described these in various waves. And what I put in there in the circle is the development or worsening of new chronic conditions. That is really part of the focus of what Alyson and I will talk about. We know that there's an interruption of care on chronic conditions. We know that there is a psychic trauma and a PTSD that occurs, as well as all of the issues around economic injury. But in the middle of all of this is also the improved and now understanding of a term called long COVID, where perhaps the acute conditions that impacted and we're worried about the hospitals are not necessarily the only thing that we need to worry about. So this is the picture of the virus that all of us are now all too familiar with. And I think that there are a number of features that give us hope that we might be able to address it. And this is not the purpose of today's talk. But it is important for us to recognize as physicians and patients and healthcare providers that there are multiple impacts on numerous biological processes that occur because of this virus. And as a consequence of that, we actually know that multiple organ systems are impacted. We know they're impacted acutely. We're not sure what the chronic effect is. And again, this is a slide from a Nature paper that is just describing for us at different points in time our evolving knowledge about what goes on in the human body when it's affected by this virus. We all know that there are multiple clinical presentations of COVID-19. You can be asymptomatic, you can have a range of symptoms, you can have major organ systems involved that are isolated or many. You can acquire it in the community, you can be hospitalized for it, and whether you're an ICU or general admission, ward admission, hospitalization, all these variations actually will impact our understanding, knowledge, and ability to learn from the condition. If I think about how we learn about any condition, we actually have to have a better understanding of the complexity of the diseases, the multiplicity of profiles, multiple environments, and the different time points that occur. And I think that as we think from a research and epidemiology perspective, how it is that we learn about conditions, we need to keep this paradigm in mind. We also need to appreciate that there are multiple interactions of lifestyles, genes, and environments whenever one is understanding an old or a new condition. So you can look up, and all of you are aware in the literature, whether it's New England Journal, JAMA, your own subspecialty journals, that every day, if not every week, there are multiple facts coming out about COVID and cardiovascular function, hematological issues, neurological, psychiatric health. And you might wonder why Alyson and I are presenting, but there's some interesting literature around kidney and lung function, which we'll share with you in a little bit more detail. So I just thought, because I'm a nephrologist, I should remind everybody that the kidney has an abundance of the ACE2 receptors that you know is how the virus gains entry into cells, and that we can see viral particles in the urine of patients. The number of case series have shown that during active infection, proteinuria and hematuria are quite common, irrespective of a change in serum creatinine, and that acute kidney injury does occur in 20% of patients, of which a minimal number require dialysis. But many of you have heard me talk about the importance of AKI in terms of long-term chronic kidney disease and cardiovascular disease. And in those people that have been biopsied, there are various severities, various pathologies, and this actually makes it all the more interesting to understand the impact of this virus. You also know that many of our patients have compromised immune systems, so there are increased risks. And that being said, in different jurisdictions, they report different incidences of COVID-19 in the different population groups. Our patients on dialysis seem to have atypical symptoms, are often afebrile. And despite all of this, in British Columbia, certainly we've had a very low incidence despite a high risk and the inevitable need for patients to come for dialysis 3 times a week, and yet did not have an overwhelming set of infections. So with that overview introduction of where we are starting, I'm going to turn it over to Alyson to tell you what we've learned about lung function, which has been much more deeply studied in this province and with some of the work. So I'm going to pass it over to you, Alyson.
Great, thank you. So as mentioned, for my portion of the talk, I'll be speaking about the post-COVID respiratory clinic and then 2 specific studies that have come out of this clinic. And the big overall purpose of this section is really to provide an example of how clinical care and research should really go hand in hand as it leads to synergistic outcomes. So just to start with some background, this is the timeline of the daily counts of COVID in BC. We know that the first case was confirmed at the end of January. And then things started to really pick up in March, and that was associated with the WHO declaring the COVID-19 pandemic, and then shortly after followed by BC declaring a public health emergency. And with the rise in the number of daily cases came the rise in patients being hospitalized. And so over March and April, we saw patients coming into hospital, but also being discharged. And we didn't really know what to do in terms of follow-up for these patients and how to counsel them on short and long-term consequences. So that is what led to the reason for creating the clinic. And in order to better understand how to counsel patients, we had to really draw on our experience from past coronavirus outbreaks. And from a respiratory perspective, we know from SARS and MERS, two other coronaviruses, that there are long-term consequences from a pulmonary perspective. So this is a study that was published in Chest on SARS, and it was a 1-year longitudinal follow-up study. And what they showed was that at 1 year after symptom onset, nearly 25% of patients had an abnormal DLCO, or abnormal gas exchange. What I found particularly striking from this study, though, was that when they collected data at 3, 6, and 12 months, there was only about 5% of patients at the 3-month visit that had an abnormal DLCO. So, and then they developed abnormal lung function later on. So what that tells us is that a patient could come in with completely normal lung function, but later on go on to develop abnormalities. But it's not just about the lungs. We also know that long-term patients can have reduced exercise capacity as well as quality of life, and a lot of psychological sequelae as well, including depression, post-traumatic stress disorder, and anxiety. So with that, we were very suspicious and anticipated that patients were going to have consequences that needed follow-up. And so in a very short time span of about a month, we put together the post-COVID-19 respiratory clinic. And along with that, in parallel, we established a research program and a registry that would go hand in hand with this clinic. And we saw our first patient on May 21st. So this clinic has 2 locations, one at VGH and one in St. Paul's. And we were able to establish an automatic referral process when patients were discharged from any hospital within the Vancouver Coastal Health region. And we tried to see the patients for their first visit within 8 to 12 weeks from symptom onset. And so far to date, we've seen about 111 patients. So this table shows the clinical and research protocol. In the top half for the clinical measurements, we collect pulmonary function tests, including respiratory muscle strength testing, the MIPS and MEPS. We do standard of care blood testing, as well as getting a CT chest and an echocardiogram. And then for the research measurements, we collect various questionnaires and a blood sample that gets biobanked. Patients then come back at 6, 12, and 24 months. And most of the investigations are repeated based on clinical indication, but everyone does get repeat pulmonary function testing. I wanted to show 2 patient cases just to highlight some of the patients that we've been seeing in clinic. So the first is a 70-year-old female, has a background of diabetes, hypertension, and dyslipidemia. She's a lifelong non-smoker and had a fairly mild course in hospital. So she was admitted for 10 days with an X-ray on admission shown here. She did not require any supplemental oxygen and just treated conservatively. When we saw her in follow-up 10 weeks after symptom onset, these are 2 axial slices of her CT chest. So on the left-hand side, we have the upper lobes that demonstrates persistent ground glass opacities. And then at the bottom, we have the ground glass as well as some reticulation suggestive of early fibrotic changes. Her corresponding pulmonary function tests are shown at the bottom, and we see that she has a mild restriction with a reduced TLC and a mild reduction in DLCO suggestive of gas exchange abnormalities. On the flip side, this is the second patient who has very similar demographics. So again, he's 70 years old, has hypertension, dyslipidemia, and GERD, also a lifelong non-smoker, but he had a much more severe course in hospital. He was mechanically ventilated for 23 days, and he had a total length in hospital of 36 days. When we saw him in follow-up, these are two similar slices of his CT chest. We see a lot more fibrotic change in this gentleman. So on the left-hand side, we see architectural distortion as well as traction bronchiectasis in the left lung. And then at the bottom, we see more reticulation and some ground glass. Not surprisingly, his pulmonary function tests again show restriction and reduction in his DLCO, but to a more severe degree. So I think these two cases, which represent fairly common findings that we were seeing in clinic, help to support the need for follow-up for these patients. And it's also very hard to predict who's going to have mild versus severe disease in hospital. So this naturally led to our first study exploring the respiratory outcomes of patients after COVID-19 infection. And this has been submitted and is under review right now. So the two objectives of our study were to first describe the clinical features, pulmonary function abnormalities, and radiologic outcomes in patients 12 weeks after symptom onset. And then we wanted to see if we can identify clinical predictors of persistent dyspnea, abnormal lung function, and imaging. And we hypothesized that patients who had more severe acute illness would have greater dyspnea and abnormalities in terms of physiology and imaging at follow-up. So in terms of methods, this was a prospective cohort study and we recruited from the clinic. The inclusion criteria are fairly standard. So adults who were hospitalized between March and May with lab confirmed SARS-CoV-2, and they had to be able to complete the surveys and provide consent. In terms of the outcomes at 12 weeks, we had 3 outcomes, so 2 co-primary outcomes. So first was dyspnea, and we measured this by using the UCSD shortness of breath questionnaire. It's a 24-item questionnaire where patients rank on a scale of 0 to 6 how dyspneic they are with activities of daily living. And then these items are added together to generate a total score that ranges from 0 to 120. And it's been validated in various pulmonary diseases. And then for the physiologic outcome, we looked specifically at DLCO, knowing that this tended to be the most abnormal outcome in past coronavirus studies. And then lastly, we looked at the total CT score for radiographic abnormalities. And we were fortunate to have Dr. Haig and Dr. Murphy at St. Paul's score the CTs for us. And what they did was they separated the lungs into 3 zones on each side and determined the percentage of reticulation and ground glass within each region. They then took the average of these zones and then created a total ground glass and reticulation score. And then they added those 2 together to generate the total CT score. In terms of the statistical analysis, we ran 4 multivariable linear regression models. So the first 3 models are looking at whether disease severity predicts the outcomes that I just went over. And we use the days on oxygen supplementation as a surrogate for disease severity. The clinical relevance of these models, the first 3, is that it would help to inform what kind of follow-up patients should have. So should they be getting a pulmonary function test? Should they be getting imaging? The 4th model that we ran was looking at if patients had persistent dyspnea at 12 weeks, is that associated with abnormal DLCO? And that would be clinically relevant because it would help to inform what kind of testing patients should have if we didn't know about their hospital stay. So moving into the results, this is the flow diagram of our patient cohort. So we had 85 referrals during our enrollment window. 16 were excluded and 69 were assessed within the clinic. We had to exclude another 9 because 5 were by telehealth and they couldn't perform the investigations. And then 4 declined to participate in research. So that left us with 60 patients for the analysis. This is a table showing the baseline characteristics. So patients on average were in their late 60s. The majority were males at 68%. Over a third of the cohort were either current or past smokers. And respiratory symptoms were, not surprisingly, very common on presentation to hospital, with 77% being dyspneic and 58% having a cough. And similar to other COVID studies, we found that hypertension and diabetes were common comorbidities in the cohort, with 35% having hypertension and 22% having diabetes. This table shows a summary of the hospital course for these patients. So on average, they were admitted for 10 days. 78% of the cohort required oxygen supplementation, and they, on average, required oxygen for 9 days. 20% of the cohort had mechanical ventilation and on average received the support for 8 days. So this is the results for our first objective to describe the respiratory outcomes at 12 weeks. For the symptoms on the left-hand side, we see that 20% still had dyspnea and cough at 12 weeks. And then in terms of the pulmonary function tests, the spirometry and lung volumes were within the normal range, but there was a mild reduction in the DLCO. For the 6-minute walk test, there was no major oxygen desaturation, and on average, people walked 96% of what we would expect, which was pretty good. From a radiographic finding at follow-up, there tended to be more ground glass than reticulation, but a significant number of people did have abnormalities on imaging. Okay, so moving into the results for our second objective, trying to find predictors of outcomes. On the left-hand side, we have summaries of the outcome and predictors for the models. And then if we, focus on the unadjusted analysis, we see that the severity of acute illness predicted an abnormal DLCO at follow-up. It also was associated with higher total CT score, which means more abnormalities on imaging. And then people who had persistent shortness of breath at 12 weeks, that was associated with an abnormal DLCO at follow-up as well. And then when we adjusted these analyses for the pre-specified covariates shown on the right-hand side, the associations remained significant. So to conclude, we found that patients, a good number of patients had persistent cough and dyspnea. There was a mild reduction in DLCO, and there were persistent CT abnormalities, particularly ground glass. And then in terms of predictors, disease severity did predict an abnormal DLCO and abnormal imaging at 12 weeks. Similarly, patients who remained short of breath at 12 weeks had an abnormal, tended to have an abnormal DLCO. So I'll now switch gears to our second study. And the background for this is that as we were reviewing the COVID literature and performing our first study, we realized that there was really a lack of studies that looked at the patient experience after COVID. And I think where we have a health system that wants to take a patient-centered approach, it's really important to understand the patient perspective. So this study was more of a descriptive study, and we wanted to understand the patient's perspective 3 months after COVID illness. And we did this by using patient-reported outcome measures, or PROMs for short. So we had 5 PROMs, and we assessed quality of life using the EQ5D. We looked at frailty with the frailty index, dyspnea or shortness of breath with the UCSD. We looked at anxiety and depression with the patient health questionnaire, and then sleep with the Pittsburgh Sleep Quality Index. Now, because we didn't have PROMs filled out by patients before COVID, we stratified them by whether they had pre-existing comorbidities from the Charlson Comorbidity Index. And this was to try and better understand whether their baseline health status affected their PROMs. So this is the list of comorbidities from the Charlson Index that we evaluated. And the Charlson has been validated in various diseases, not just pulmonary diseases. And it's also been associated with things like poor lung function and mortality. So what we found was that 76% of our cohort had at least one abnormal PROM, which are each shown here in panels. So these are dot plots, and each patient is represented by a dot. So those with a blue dot had no Charlson comorbidities, and those in red had at least one. The normal range is shaded in gray, and where possible, we tried to use population norms. So if we look at quality of life at the top left, we see that 51% of the patients are outside the gray region, and so they had an abnormal response in quality of life. And then for frailty, dyspnea, and sleep, about 40 to 50% had impairment. And then for mood, 24% reported an impairment to suggest anxiety or depression. We then wanted to explore a little bit more about quality of life, since that was the most impacted PROM. And this is the questionnaire for the EQ5D. There are 5 domains that represent different aspects of quality of life, including mobility, self-care, the ability to perform usual activities, pain or discomfort, and anxiety or depression. Patients select one box for each of these domains, and they select the severity for that domain. This is a histogram representing the proportion or the percentage of patients who reported at least a moderate impairment in each of these domains. The black bars are for the total cohort. The red bars are for patients who had a Charlson comorbidity present. And we can see that the highest bar with over 20% of patients reported at least a moderate impairment in anxiety or depression, whereas people who had no Charlson comorbidities tended to have impact in ability to perform usual activities. So the conclusion from this study is that patients experience a really diverse range of impairments that go well beyond the respiratory sequelae that we found in our first study. And this really supports a multidisciplinary approach in providing a comprehensive care that clearly patients need. In terms of the future directions, so the next study that we'll be starting is to look at biomarkers that are associated with the development of post-COVID fibrosis, and then transitioning to the Interdisciplinary Clinical Care and Research Network, which Dr. Levin will speak more about. And I think this approach really allows for different disciplines to work together to provide that comprehensive care rather than working in independent silos. And then from a research perspective, there are nearly 400 COVID studies going on in BC. And so in order to minimize the research burden on patients, as well as to give each study the best chance of success, having a central hub for research really makes sense. So with that, I will hand it back over to Dr. Levin.
Thanks, Alyson, and thank you for that very lovely in-depth review and an example of how important it is to do systematic follow-up in a group of people. And I think struck am I by the fact that when you don't have any comorbidities, you still have an impact of having had the disease if you were hospitalized. And I think that's something that we as clinicians and researchers need to pay attention to. I wanted to just give us some updated context and alert this audience and others to the fact that there is a COVID-19 cloud analytics group based out of PHSA, and I thank Lexi and Agnieszka for the slides that I'm about to show you on a very high level, but just to give you a sense of where we are in the kind of modeling that's getting done in this province. Here we go again. I can't move it, there we go. So these are the sources of data that exist within the province. Some are ministry related, some are PHSA related, and some are regional health authority related. You can see with the different colors where these are, but there are laboratory, population, hospital, public health, vital stats, mortality, and other healthcare services all available within this cloud. And from that, the idea is that there will be an application of advanced analytics to help inform how we manage going forward. And I thought that it was important that this group understand that this health system operational modeling is going on as a collaborative between the ministry and others, trying to make sure that we build out testing, contact tracing, and case management capacity in real time, but also, as you can see by some of those bullets, protecting other patients. I just want to show you some high-level examples of some analytics that demonstrate how we can use this information. So this is a timeline from January to August 22nd that describes the age distribution of people who are affected by COVID. And you all know, because you listen to the news, that there are more cases now than there were at the peak, but importantly, the distribution of those age groups, and it's younger people getting sick now, albeit not all hospitalized. This is a graph showing that over the different phases, phase 1 is the beginning prior to May, phase 2 is May to June, and phase 3 is June to August, that different age groups have different hospitalization groups, but obviously we are not hospitalizing as many people in any of the age groups in this last phase as we were earlier. And similarly, going into ICU, there's been some change in the older population. This is the risk profile that also looks to be changing. We have a way to monitor comorbidities. There are some chronic disease registries, which I'm not going to bore you with, but basically the green is no comorbidity, the dark blue is more than 4, and you can see that people who have no comorbidities, which would go along with the age distribution that I just showed you, are getting COVID now. And back to Alyson's slides, I think it's really important to remember that people who were never sick before still have residual impact of this condition. This is by comorbidity, hospitalizations, and ICU, a similar diagram. Again, the point is that we have this data available, which should help us to model and think about care paradigms. And then this I thought was interesting because when they looked specifically at the various comorbidities, the 4 that come out on top are diabetes, gout, chronic kidney diseases, and respiratory conditions as being most likely to be associated with hospitalization. That's not ICUs, that's all hospitalizations. And those are pre-existing chronic conditions, whether or not they're known to a specialist, but rather they have these conditions according to various coding strategies. And I think this is important for us as we think about how to care for this group of patients. And if I think about how we need to have optimal and integrated care of individuals, this is a slide that I've used in other venues, but it applies here too. We need a scientific understanding of the disease or diseases that we're looking at. We need to be able to identify it, the people at risk, and then apply our knowledge of best therapies and develop them effectively. But importantly, we need a supportive health environment. And I think that that's part of what we're trying to create in BC. There are a number of public health strategies, and as Alyson very clearly articulated, defining what the problem is and what you're trying to understand from a research and a clinical perspective is very important. And so whilst we're looking at the size of the problem and looking at causes and risk factors, we're also at the same time worldwide trying to develop and test interventions and then get them implemented in real-time practice. But importantly, to have equitable access to all of this province-wide. So I showed you this slide before, but I want to remind you that what Alyson showed you and what I've just shown you with the Ministry of Health, sort of the COVID cloud data, is that this disease is not one disease. It does not affect one group of people. There are multiple profiles and multiple environments, and at different points in time, we're going to see an evolution of this, and we really do need to understand that best. So we have to create the evidence to inform practice. We need to have a better understanding, and people are working on that around the world, and some of that work is being done in BC as well. We really need to clearly identify patient profiles, and we have to have responsible ordering of tests for both surveillance, diagnosis, and the monitoring of response to interventions, which begs the question of how would we manage these complex patients, and how do we make sure that we keep our focus really on patients, and that's what should drive the collaboration that Alyson was talking about. So how do we care for people across the continuum, whether they have symptoms or not, whether they ever see a hospital or not, and within different healthcare structures, because rural and remote and urban are different, and there are different access issues. So the other problem is, in this kind of era of COVID-19, we have a number of challenges to delivering clinical care, don't we? So we have physical distancing, so we can't bring people in the same way. We have to stagger visits. We have a reduction in access to services, in some part driven by patients' fear, and other parts because of cleaning and other issues. We have a reduction in access to certain services and clinical care teams, with a lot of changes in the way that we look at person visits. Masks, gloves, and gowns certainly reduce our ability to deliver what we like to believe is humane care. Certainly the no visitor and even difficulty with interpreters with our multilingual and multi-ethnic populations, difficulties and fear of transportation. How do we actually preserve our humanity while caring for these people? And how do we actually learn in this rapidly changing environment that, as I said, isn't anything that we all signed up for at the beginning? And so we've asked the question, why would we want to follow people who've had COVID-19, even if they don't have symptoms now, or if they've fully recovered? Well, I think we've started to set this up so that we begin to think about what would be the progression of condition or organs affected acutely. Is it stable over time? Does it change over time? How do you actually plan for transitions? How does this virus affect other conditions pre-existing, whether that's lung and cardiovascular, kidney, or underlying psychiatric conditions and depression? And I think from a ministry perspective and a healthcare systems perspective, how do we actually look at long-term impact on healthcare systems and how we use resources if we actually don't know what's coming? And if you think about the components of care that are important for patients and for us, is we need to educate people. And part of this rounds, for example, has been offered to the patients that were on our group and others, and hopefully through an increased public awareness, we'll actually understand various values. There are increasing reports about things to do to prevent or reduce your ability to be susceptible to the virus, and I think that's important. We need to have surveillance as part of our care, because as Alyson pointed out, you will have changes even if you didn't overtly have problems, and there are a lot we don't know. And we have to help people navigate through the system with access to specialist procedures and research protocols. And when different treatments are shown to be effective either in prevention or attenuation, we need to actually make sure that those are available to people as they come up. So the silver lining of all of this COVID stuff in BC has been the unexpected consequence that we do have enhanced access to virtual platforms. So we can see people without bringing them all into physical clinics. I think I'd speak for all of us that there's been a renewed collegiality to get things done and get collaborations across divisions, disciplines, and organizations. And for that, I think we're all very grateful and excited. And there's so many questions, and I've just listed them here. Like, what's the burden of illness in those who were and were not hospitalized? We don't know. We don't know how long the signs and symptoms last. There's more and more reports about something called long COVID, which is something that kind of carries on. We don't know the best way to offer follow-up care. We don't know what health system and community resources are required, or who is best suited to provide that care in this virtual environment, and how we disseminate things that we know in a timely manner. And interestingly, I came across this advocacy working group for the House of Lords in the UK, and they're asking exactly the same questions. I'm not going to read them, but they want to understand overall long-term health implications. Because I'm a nephrologist, I was curious about what they want to know about the damage to kidneys, but they're also asking things like, does the NHS have the capacity to provide treatment for the number of patients if in fact chronic kidney disease is something that is extenuated? And I could take that to cardiovascular or respiratory disease as well. And again, this long COVID, what healthcare services and treatments can assist us with better understanding. And I think the fact that everyone is asking these questions is very important for us to reflect on here in BC. So how do you actually get research and collaboration in the context of a new disease? Well, I think that you integrate it within clinical care in the context of a learning health system, and you actually get clinicians, patients, and researchers to work together. And that will let us develop clinical care models in the COVID era that increase our opportunities for all sorts of interactions, efficiencies, and importantly, informed by and participated in by patients, because patients are very interested in knowing what will happen to them and helping to participate in that knowledge translation and acquisition as well. So as Alyson alluded to, the existing respiratory clinics really were a model for what to do. And we got to here with this group of collaborative people trying to work out how best to integrate research and care from these existing respiratory clinics under the direction of Chris Carlston, Chris Ryerson, and Jay Johnson. And they recognized the need that as they were seeing these patients, they were multi-organ issues. There was also increasing evidence that there was a lot of research proposals coming forward, and that we probably needed a learning health system approach given the multiplicity of unknowns for this condition. And so we got 60 clinicians, researchers, and patients. And to be frank, they have met virtually since March of this year, sometimes weekly or twice a week, and developed with the support of a symphony of people the following. So there's a commitment clinically to have standardized intake assessment proposals, to integrate medical, psychosocial, and social supports within the context of clinical care, to make sure that we have rapid access to special expertise as needed from a common intake hub, to make sure that we make virtual care accessible where and as required, and ensure that we have centralized data collection to make sure that we have rapid change for the best care and also access to rigorous research. And I think that that's pretty novel in many, many ways. Oops, what happened here? So just to go back, to have any kind of a model of care, you need to define populations in a consistent manner. You need to consider the development of care models that are specific to the stages and the unique conditions and a constellation of high-risk conditions. And so as we are thinking about how best to develop these care models integrated with research, we need to think in a very rigorous way, as we would do in any research protocol, but do this from a context of clinical as well. We need to recognize that it's complicated to take care of people, and we need to integrate, and that longitudinal, regular, multidisciplinary, and evidence-based care should be at the crux of everything that we do, and that collaboration between primary care and specialties is essential, as is between specialties. So what our goal is to provide a province-wide network of kidneys that will provide this coordinated care, coordinated research, and a sharing of information. And importantly, we want to make sure that there's easy access to the right tests and avoiding unnecessary duplication. We want to make sure that we can share the results between scientists, clinicians, and health policymakers while reducing the burden on patients, and share all the information and link data so that we can inform real-time care, but also long-term needs. And so our proposal for an integrated provincial network looks something like this. As a network, a learning health system includes the BC community, people at risk, and people who have tested positive for COVID, who are either hospitalized or non-hospitalized, and all should have a primary care physician, and some will have specialists. And we are proposing a network of these interdisciplinary clinical care clinics in each of the different health authorities, embedded on a firm foundation of research where there are clinical protocols, interventional trials, and the ability to have biobanking available for all who agree that will actually help to further inform care. And the notion is that these clinics are a one-stop shop. They integrate clinical care and services, and they connect anyone within the context of COVID-19. And they may serve as a model for other things, and it's truly an amazing collaboration, if you will, of multiple different groups. And we've developed, and this is mostly the work of the internal medicine group working with the respiratory group under different leaderships, including Jane McKay, Jesse, Zach Schwartz, and Peter Burks, but how you would actually conceptualize registering everybody, no matter where they had their, had their illness, register them, and then actually have this ongoing care plan and standardized evaluation. The standardized tests would ascertain the burden and the consequences, irrespective of symptoms, because we don't know what we don't know. And I think that's a really important component of this learning health system. We would then be able to determine the utility and discriminatory value of different tests and also facilitate referral. So where we're at, we actually have a provincial post-COVID care race line where calls are answered by dedicated internal medicine physicians from Providence, Vancouver General, and Fraser Health, and that's a shared responsibility to help with consistency and learning, and that's being tracked in terms of the sorts of questions that GPs and other specialists are asking. The Providence Healthcare Recovery Clinic is starting, and VGH is going to be launched early in the fall, and Fraser is under development. We are developing a set of interdisciplinary and accessible educational rounds and clinical review round schedule, which is predicated on obviously a number of things, including published literature synthesis as well as experience literature. And we have ongoing patient engagement with our partners, both through the BC Support Unit, other provincial patient-oriented networks, as well as the academic health sciences group. And I think that's been a really amazing grounding experience to have patients help tell us what they will and won't do when they do come to these clinical events. So we aren't the only ones doing this, to be fair. Mount Sinai in New York has a post-COVID care clinic, and if you go to their website, you'll find a lot of words that sound like what we just used, but actually it's in one center in one location. There's a recent publication on August 26th in JAMA that describes a multidisciplinary COVID-19 follow-up clinic in the University of Hospital Birmingham in England, and we're in conversation with them to see if we can do some collaborative work. And this is all predicated on the fact that people are starting to understand that this COVID-19 virus isn't something that you necessarily recover completely from, and it may trigger in susceptible individuals other longer term or short term consequences. So I wanted us to imagine that we're developing a patient-centered, integrated research and clinical care network. And this sticky little virus managed to get a whole bunch of different groups of people and organizations together, really with patients at the center. And I think that that's a huge bone. We aren't there yet, and it isn't fully developed, and it's still an idea. But I think we are slowly making progress towards it. And so with that, I'd like to end and maybe open it up for questions. We have many, and there are lots of opportunities to answer them. And I want to thank Alyson and the whole respiratory group and all of the people that have been involved to date for allowing me to present on your behalf some of the ideas and thoughts that have been evolving, but mostly to thank Anita for the opportunity to start out this September year, if you will, with something hopefully positive and exciting that helps us to make some sense of this new world. Thanks very much.
Thank you so much, Alyson and Adeera. And the floor is open for questions. You can ask them yourselves, or if you want me to put them in the chat, we welcome them.
Anita, it's Barry.
Yes, go ahead.
Hi, thank you both for presenting the information, and thanks for the update on the status of the COVID clinic. I have a few questions, and so probably not original, probably ones you've asked yourself, but maybe you could at least be explicit. Have either of you, or have you seen in the literature, an approach to an illness that we don't have an illness script for, that is, as we're evolving this illness script and targeting, or at least observing different components of the body that are affected, we're also at the same time proposing different ways of intervening to study, to approach this with an incomplete approach. That would be number one. Number two.
time. It's easier one at a time.
Okay, sorry. I don't want to monopolize it. Do you want me to ask the questions now or just one at a time?
Maybe one at a time is just
Sure.
easier. That's okay. So the short answer is that HIV is the one model that comes to mind where people did appreciate from the beginning that we had to learn and test as we went. And setting up of formal abilities to do that was very much the way of HIV. Cancer has evolved that, but not from a new disease. It was a known disease, but I think, and so the culture that we're proposing isn't 100% foreign, but the need for it to be more nimble and adaptive. And we also now have we have newer ways of developing platform trials and adaptive trials. So I'm hoping that this is one of those send-offs.
Go ahead with your second question, Barry.
So the other component is just related to Dr. Wong's presentation and the observations of patients that are studied after their illness that are released from hospital. There was a data looking at the radiology and the pulmonary function parameters. I don't know if that data was compared to other patients that had been having similar issues in hospital, but not COVID related. That's the first part of the question. And the second is using the qualitative pieces of information you decided on impact. How do you assess that when COVID is on the news and in the newspapers on a daily basis, whereas pneumococcal pneumonia is not?
Yeah, so the first question is whether we basically compared to a control, and we did not. It was just hospitalized patients, and I think that is definitely ongoing areas of research where we want to compare to various groups. So those who aren't hospitalized versus those who are, versus people who are healthy, quote unquote, healthy controls and may not necessarily have COVID. So that is something that I think is ongoing and would be a great project that stems out of the interdisciplinary research network, because right now—
The question though was specifically related to those patients that have been hospitalized with other illnesses. So pneumonia on the medical ward or pneumonia in the ICU, and how their results would compare with what you're looking at.
Sorry, I might not fully understand. So you're talking about within our cohort who are all hospitalized for COVID pneumonia?
No, I understand. Sorry, what I'm asking is so in a control group of similar patients with non-COVID disease that we looked at post-hospitalization.
That I am not sure. I don't know if, I mean, the similar cohort would be like an ARDS population, although that would be a more severe illness. And we know that with them, they tend to have post-ARDS fibrosis as well, with abnormal pulmonary function testing and imaging. So I would say those two cohorts are similar, but in terms of people who didn't have ARDS related non-COVID pneumonia, I'm not sure.
I think, Barry, you raise an interesting question that, you know, we're doing all this, we're so interested in COVID now that that's all we can think about. But in the context of general diseases, what do we know about people with pneumococcal pneumonia who got admitted to hospital and went home because we have this kind of systematic follow-up of them? Is that what you're asking?
Exactly.
Yeah, so I think it's an interesting thing. And again, I think the value of this condition is that it's stimulating all of us to ask these questions about what should we have systematic follow-up of all hospitalized patients? Like, what would be the value of that? Would we in fact, you know, be more able to implement preventative measures? Would we learn more about many diseases if we thought more systematically? And I think to me, that's the value of a research and clinical lens working together.
And then the final part of that is when you're looking at the qualitative research that you were doing by interviewing people, it's pretty hard to look at that information out of context since COVID is in the news and in the papers on a daily basis, whereas pneumococcal pneumonia and other diseases aren't. So, I mean, it's just hard to interpret that type of research.
fair. I mean, I think it basically identifies areas of research that we really need to explore. And I think just in general, qualitative research is just underperformed and integrated into clinical research. But I agree with you that there might be some bias related to people's perception because it is so much at the forefront of media.
Thank you.
Any other questions? You explained it so well. You know, and I just want to comment, I don't even know if it is really a bias. It's what patients are experiencing in this world right now. This is what it is, right? So the media is there, and that's what, they're in the same ecosystem we're all in. They've experienced a potentially mild to severe illness, may have residual symptoms, and they're processing all of that. So I think it's just part of what they're experiencing. Yeah.
Yeah, and
I
again,
think
maybe
there's a lot of anxiety. Yeah.
and maybe we've underappreciated the amount of anxiety that all of our patients who are hospitalized
Mm-hmm.
experience, but we've never had concentrated effort into thinking about it. And so we will all anecdotally be able to explain or describe this, but perhaps it gives us a chance to say, hey, being hospitalized is a traumatic event for whatever reason. And what is it that we do to make people appreciate that more? So Barry, your points are well taken, but it isn't a bias. It's maybe just that we've concentrated our efforts on learning a lot about this group of patients. And perhaps it's a call to, shouldn't we be this curious about all of our patients?
Adeera, you said it way better than I could say it. But I absolutely agree. I think that I don't think we can underestimate the impact of us and hospitalizations on anybody. And I think that this is beginning to show that. So thank you.
Can I just say one little tiny thing about that?
Yes, go ahead.
Chris Carlson, one thing that I know we're ending with, one of the most fascinating things about this to me is this development of kind of a, there's different names for it. COVID syndrome looks a little bit like chronic fatigue syndrome. You don't want to put these labels on it, but whatever that is, I mean, I think laced into what everyone's been saying, when was the last time that topic got serious attention in major medical journals? And suddenly it's COVID and it's all over the headlines. And, people who have whatever that thing is, and it's probably multifactorial, blah, 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 it's no fun. It's serious. It can ruin lives. And, it's always been an unpleasant topic, generally speaking, for the clinician. And now suddenly it's getting more attention. So I think that's a really, I don't even know what it all means, but just that observation to me is kind of a fascinating offshoot of everything we're saying.
Thank you, Chris. It's a really important observation, and I expect we're going to get much more attention, and hopefully all the patients who are affected by this condition can benefit. There's a great comment, maybe Adeera, you can address it, around supportive resources for patients.
So part of developing the clinics is that we will be able to assess what kind of supportive services they need. One of the important things is for us to create appropriate business cases and to our institutions and others to ensure that the support services are available. Some exist in the community, some exist within institutions, but we will very much need to understand that. That was part of the reason that I put up that House of Lords slide, because the NHS is asking these questions, and I know that Ministry of Health here is also asking them, but we perhaps need to help answer them in real time so that we can actually provide some of those services sooner than later. But thank you, and I think it is trying to be built into all the research endeavors, the availability of access to and consequence of having support services, and those that don't, so that we can actually show a difference.
Adeera, I have one additional question. You spoke about the NHS and a few, like Mount Sinai, a few centers that the group has connected with. Just in light of kind of the rather chilling Washington Post, Bergamo kind of outcomes that's in the media, but I haven't seen it formally published in any medical journals as yet. Have we connected with the Italian groups to kind of see and coordinate? Obviously, there will be some synergies there, I'm sure.
It's a great question, Marla. Formally, no. I mean, we know the people in Bergamo. I think they had such a different experience, and their healthcare system is so different. So the UK is much more similar to us. I think that, you know, a network of networks is ultimately a great goal. But we do have intelligence from all of those places, but they have barely recovered in Bergamo to have anything even close to, quote, formal clinics. And it's also a private system in northern Italy, so it's a combination of problems. That it's a combination of private and public, so it's going to be a little harder to do it. But great questions, and I think that all of us who've been involved in this do have multiple international and national connections. So we are trying, but in the first instance, we're trying to at least do something standardized and effective in this province, informed by all of those. Thanks for the reminder.
I'm sure both Adeera and Alyson would be happy to take questions offline. I'm just mindful of time, and I want to thank everybody's attention, and especially thank the speakers and everyone who's been involved in this initiative. We are so grateful for all of your energy and work during a very difficult time, but it has paid off, and I think it's going to hopefully help the citizens of British Columbia who've been affected by this condition, and hopefully help them get better, and that we could all learn together. So thank you so much.
Thanks for inviting us.
Great, thank you.
Welcome.